Hi everyone, this is Dr. V. Din from Loma Linda, and in this lecture we're going to go over basic cardiac ultrasound. So the goal is for you to obtain 4 cardiac views after this talk. The 4 basic views of cardiac ultrasound are the peristernal long axis, peristernal short axis, apical 4 chamber, and the subxiphoid view. Regarding probe selection, you want to use a phased array probe. And the reason for that is, as you can see, it has a small footprint compared to, let's say, a curvilinear probe. And it also has low frequency, which allows it to have good penetration and depth. Every machine is going to be a little bit different, but you want to make sure you change the preset on your machine to cardiac mode. And you make sure you just click on cardiac mode. And if sometimes they have a difficult setting also, which allows for patients with more difficult penetration. So regarding the patient position, you can have them supine, but ideally you want to have them in left lateral decubitus. The reason for this is the heart's usually right behind the sternum, and by putting a patient in left lateral decubitus position, it shifts the heart from the sternum more towards the left side, where you can actually view the heart and not go through any type of bone or any other interference. Which way does the indicator go? Now, this is probably the most confusing part of cardiac ultrasound, and even seasoned sonographers sometimes get confused. So the indicator location. So the standard way is to have the indicator dot on the left side of the screen, but in cardiology mode, for the most part, and just check this right before you start scanning, the indicator is on the right side of the screen. It's really the only mode that has the indicator on the right side of the screen. So if you're in standard mode, for a peristernal long axis view, which is generally the view you're going to start off with, the indicator is going to be towards the left hip. However, if you're in cardiology mode, the peristernal long axis view, the indicator will be towards the right shoulder. So if you don't really remember that, or you don't like memorizing things, you can remember the 3 L's to success. For the peristernal long axis view, the left ventricle will always be on the left side of the screen. So if you ever see an image that looks like this, the left ventricle is on the right side of the screen, you know that you just need to flip your transducer 180 degrees, and it will look like this. So rotate 180 degrees. So when you're doing anything, you should have a protocol, and this helps you keep things in mind so you don't miss things. This is the order that I like to go through. So number 1 is a peristernal long axis view. Number 2 is a peristernal short axis view. Number 3 is the apical 4 chamber view. And lastly, end off with a subxiphoid view. For this talk, we're going to go through everything in the cardiology view. So the first one is going to be the peristernal long axis view. And like we said before, the indicator, as you can see, is pointing towards the patient's right shoulder. And it's next to the sternum, hence the word peristernal. And you're going to start it right at the nipple line around the 4th intercostal space, and make sure you keep the probe perpendicular to the skin, and you can move up and down next to the sternum. So think about it this way. You see how the heart on this chest x-ray is right behind the sternum. So we know this by looking at x-rays, but a lot of times people will start on the left side. So if for some reason, let's say you start at the 4th intercostal space and you don't see any heart, just hug the sternum, scan down or inferiorly, and you eventually see the heart. An easy way of thinking about scanning for cardiac ultrasound is really focusing on the left ventricle. And I think of the left ventricle as an ice cream cone, specifically the cone portion of it, and maybe the ice cream can be the left atrium. So if you think of the left ventricle as a cone, everything really revolves around the left ventricle, since it's so much bigger than any of the other chambers in a normal patient. So you have the apex, you have the base, you have the anterior portion and the inferior portion. And for cardiology, they go anterior-inferior instead of the anterior-posterior. So here you can see this is what a peristernal long axis would look like, and this is the view that you want to see. Here are some of the structures you want to identify. So most anteriorly is going to be right ventricle, left ventricle, the left ventricular outflow tract, and the left atrium are the structures you want to identify below the RV. And here's how it looks in real time. The second view you want to obtain is a parasternal short axis view. So how to obtain that, you rotate your probe clockwise 90 degrees after you get the parasternal long axis view. So now the indicator is towards the left shoulder. So now it's towards the left shoulder. Initially it's towards the right shoulder, and now it's towards the left shoulder. So once again, thinking about that left ventricle as a cone, okay? So initially you had it on the long axis. Now if you turn it 90 degrees, you're going to see what looks like a circle because it's just like a cone, right? And that's exactly what you should see. You should see a really nice circle for that parasternal short axis view, and there's a few different views you can get on the parasternal short axis view. Depending on where you cut or where you turn your probe, you're going to cut different portions of the cone or the left ventricle. You're going to see different views. So if you cut it right at the papillary muscles, you're going to get a mid-papillary view. And this is what it looks like there, where you can see both of the papillary muscles, the interventricular septum, the left ventricle, and the right ventricle. And this is how it looks like in an actual patient. And if you cut it a little bit more towards the base, right, you're going to hit that mitral valve, and this is called a fish mouth view. And you just slide that basically more medially, and you usually get this view. And here you can see the right ventricle, the mitral valve, the anterior and posterior leaflets, and it kind of looks like a fish mouth, right? They're opening and closing. And if you tilt your probe, you can see the aortic valve or the Mercedes-Benz sign. This is even more at the base of the heart. So right here you can see the structures in this short axis view that include the right atrium, the right ventricle, the right ventricular outflow tract, and the left atrium. This is honestly the most difficult view to obtain, so if you can't initially get this view, don't worry about it. But we do cover this just to be a little bit more comprehensive. And this is how it looks like in a real patient. So the third view is going to be the apical four-chamber view, and a lot of times this is one of the most difficult views to obtain for novice sonographers, but we'll show you a way that makes it a lot easier to get. So the apical four-chamber view, the indicator is still going to be towards the left side of the patient. However, you just slide it down where the apex is and just tilt it, and you should be able to get the apical four-chamber. So once again, coming back to this cone analogy, so now we have the short axis, right? It's a nice circle, okay? And depending on where you cut this cone, like we saw, if you're either towards the apex or the base, if it's right at the base of the heart, it's going to be a big circle, right? And as you go closer and closer to the apex, the circle, as you cut in cross-section, or the cone you cut in cross-section, will have smaller and smaller circles until eventually you hit the apex where it's really small to no ultrasound image. And you eventually what I call falling off the cliff, where it kind of falls off and you see no ultrasound image. So what you can do is you can slide your probe and see the circles getting smaller and smaller until it disappears, and that's how you identify your apex. And make sure you're continuing to stay perpendicular to the heart. Remember to get perfect circles as you come down. And if you tilt your probe on that apex right there, then you get your apical four-chamber view. That's going to be your left ventricle on the screen. And this is exactly how it looks like for apical four-chamber view. So once again, just think about it as a cone, sliding it down towards the apex and obtaining it there. It might be more difficult for female patients, but this gives you good practice, especially on male patients, on finding the apical four-chamber view. The structures to identify in the apical four-chamber view are going to be your left ventricle, left atrium, right ventricle, right atrium, mitral valve, and tricuspid valve. The last view is going to be the subxiphoid view, or if you want to remember it, sometimes I call it the subhepatic view, just so you remind yourself that you really need to go through the liver to obtain this view. So for the subxiphoid view, once again, the indicator is going to be towards the patient's left side. And this is kind of a schematic of what it would look like, or what we're scanning. And this is what you're going to see on the subxiphoid view. And the structure you're going to identify are, one is the liver, so you have to go through liver before you see any of the other structures, as well as the right ventricle, right atrium, left ventricle, and left atrium. And here's how it looks like in real time. So the reason, we talked about the subxiphoid view being called the subhepatic view, and sometimes it's difficult for people to get. So what you can do is you can really start on the right, find the liver first, and then sweep in the middle to find your subxiphoid view. Sometimes that's the easiest way to look for it because you have to go through liver. The errors I see normally for the subxiphoid view are people start right in the middle or towards the right, and they're going through stomach and air and gas bubbles, and that's going to scatter all your ultrasound waves, and you won't be able to get a subxiphoid view. So putting it all together, we went through a lot, but here's how everything looks. So initially, right, the indicator is towards the patient's right shoulder, and you get the parasternal long axis view. And the second view, remember, you're going to rotate 90 degrees clockwise, and the indicator is going to be towards the left shoulder. You can see that person moving the hand there. So now the indicator you see is towards the left shoulder, and that's how it would look like. Remember, you're looking for a nice circle. If you see anything other than a circle that looks like an egg shape or oval shape, then you know you're not at the correct axis. You have to tilt your probe a little bit to make sure it's a perfect circle, or as perfect as can be. So the third view is your apical four-chamber. So now you're going to slide your probe as you see the circle is getting smaller and smaller as you're going down the cone, and eventually you're going to tilt on that apex. And this is what it looks like. So you see I'm sliding the probe down, circles get smaller, and then I tilt on it right when I don't see any more cardiac motion, because I know I'm past the apex, and this is what the apical four-chamber should look like. And once again, the indicator is still towards the patient's left side. And fourth and the last view is all you have to do is place your hand over the probe and bring it just below the xiphoid. So I'm placing my hand over the probe, and I'm starting to the right, and I'm sweeping in. And once again, the indicator is still towards the patient's left. And the reason you ain't going to want your hand over the probe is that if your hand is underneath the probe, you might not be able to get the right angle. You see how close the probe is to the patient's skin, because it's a really shallow angle when looking for the subxiphoid view. So in summary, the 3 L's have a systematic protocol. Right, you can do the parasternal long axis using the 3L technique. You can get the parasternal short axis, get the apical four-chamber, end off with the subxiphoid view. And as you saw, it's really easy. Just let all the views guide you. Just go one by one in the same sequence each and every time. We're going to go over inferior vena cava just really briefly. So how I like to do it is I like to find the IVC in a transverse view and then rotate 90 degrees. So I look for that first and then rotate 90 degrees. And depending on if a patient is spontaneously breathing or mechanically ventilated, the phases of when the IVC is larger or smaller will be different. So for a spontaneously breathing patient, when they breathe in is when the IVC is the smallest. However, for a mechanically ventilated patient, since they have positive pressure, their IVC is going to be largest during inspiration. And I'm going to go back to that one slide. So what you're really looking for IVC is it collapsible or not? So if it's more than 50% collapsible, you know the right atrial pressures are low. If their IVC is less than 50% collapsible, then you know the right atrial pressures are more than 10. But all that tells you is the right atrial pressure. It doesn't tell you that they don't need fluids. If their IVC is really collapsible, then it says that they can tolerate fluids, but probably without affecting their lungs or significant adverse effects. So just take it with a grain of salt. Talk to your residents or faculty to make sure that you understand the meaning of the IVC collapsibility. Here's some cardiac pathology. So here's some must-know diagnoses, and these are really easy to see, right? So cardiac standstill, when you're in a code, is really helpful. Any type of pericardial effusion or tamponade, right ventricular strain, and estimation of ejection fraction. So cardiac standstill. So let's say you're in a code situation, and you don't, the team is unsure when to stop. So what you can do is you can do a quick ultrasound of the heart using any view you can get, parasternal long or subxiphoid, probably the two most common views to get. And you see here that this subxiphoid view, this patient has no cardiac activity whatsoever. And cardiac standstill has been associated with basically almost 100% mortality in a code setting, unless the patient is hypothermic or certain specific drug overdoses. But for the most part, if you see cardiac standstill for a code, for cardiac arrest, almost never do they have return of spontaneous circulation. Pericardial effusion and tamponade. So here's a normal heart here. And what you really want to make sure you identify is the descending aorta, and that's usually just posterior to the left atrium. And the reason that's important is that a pericardial effusion will be anterior to that descending aorta, and a pleural effusion will be posterior to that. In this patient, they have both. They have both. The pericardial effusion is indicated by the yellow star, and the pleural effusion is indicated by the red star. They're both anechoic, fluid-filled, and that descending aorta really helps you differentiate between those two. Here's another example of a pericardial effusion, and actually you can see the heart swaying back and forth. Here is a pericardial effusion, and this is just to notice that sometimes this is actually a subxiphoid view, and this is liver over here. I don't know if you can see my my arrow right here, okay? And right here is a black area right here. That's actually ascites, okay? That's ascites right there. And here is actually your pericardial effusion. So make sure that when you're scanning the subxiphoid view, you're in a especially a patient with liver disease, that you're not looking at ascites, and it is truly ascites. However, a lot of patients with liver disease also have kidney disease, and end-stage renal disease can also give you pericardial effusion sometimes. So just make sure you look at it in the correct context. So tamponade, the definition is going to be right ventricular diastolic collapse on ultrasound. So here is a patient with tamponade. You can see the right ventricle here, okay, is not filling completely. You see it's collapsing even during diastole where it should be filling. Here's another example of a parasternal long axis view where the right ventricle here, you can see it's not filling, it's collapsing during diastole. The next pathology is going to be massive pulmonary embolism, and what you're going to be looking for is basically right ventricular strain. The normal RV size is about 1/3 to 2/3 the size of the left ventricle. So a rule of thumb is if the right ventricle is the size of the left ventricle or larger, then you know there's some RV strain or there's some RV hypertrophy there. So here you can see that this RV is barely moving this wall, this anterior wall, and the size of this RV is actually even larger than this left ventricle. So you know that there's some RV strain there. This is a normal heart. You see how this right ventricle is definitely smaller than this left ventricle over here, and see how well it's moving in towards that apex versus the previous slide. Another sign you might hear is called the McConnell sign, where you have a hyperkinetic apex. So there's a lot of things that can cause RV strain, so don't always think RV strain equals massive pulmonary embolism, because anything like really, that gives you high pressures in your right ventricle is going to give you RV strain. Any type of pulmonary hypertension, even things like left-sided heart disease might also affect the right-sided pressures. So, but if you see McConnell sign, where you see this hyperdynamic or hyperkinetic apex, that's been shown to be a specific sign for pulmonary embolism. Another sign that you can see sometimes is called the D sign. So there's so much pressure in the RV that starts to push against the interventricular septum and prevents the left ventricle from filling. So this is called a D sign, and that's why it looks like a D. The LV looks like a D. Estimating ejection fraction. So here's a normal heart, and you can see the mitral valve is almost hitting the septum, and the left ventricle, the walls are contracting really well and almost touching each other. Compare that to a patient. This is apical four-chain review. This is a patient has depressed activity, probably moderate to severely depressed, but probably more on the moderate side. And you can see the LV is not really moving in towards each other that well. The walls, as well as the mitral valve, is not really moving that well. This is a patient with severely depressed ejection fraction, where the walls are barely even moving at all. And once again, this mitral valve is not really slapping up against that septum like in a normal patient. So just in summary, just make sure you know these common pathologies will really help you during your rotations, as well as during your residency. And thank you very much.